People who are morbidly obese die much younger. For example, a 40-year-old female with a BMI of 40 will die up to 10 years earlier. The reason for this is that diabetes, hypertension, cardiac abnormalities and sleep disorders, including sleep apnea, are all much more common and made worse by obesity. Another way of putting it is that the risk of dying at any given age is more than doubled at BMI 40 and more than quadrupled at BMI 50. Why then should anyone consider surgery? This actuarial life table analysis illustrates the rationale for surgical intervention. The vertical or y-axis represents risk of dying. The horizontal or x-axis denotes BMI. You can see that as the BMI increases beyond 25 kilograms per meter squared, the risk of dying at any given age also increases. After a BMI of 40 kilograms per meter squared is reached, the graph gets much steeper for both sexes. In other words, for a small increase in weight, there's a proportionately exponential increase in risk of dying. Who qualifies for surgery? All patients who are morbidly obese, that is BMI 40 kilograms per meter squared, and who fail all conservative means of weight loss should be considered for surgery. Furthermore, any patient with a body mass index of 35 or greater who has reversible obesity-related medical conditions such as diabetes, hypertension, sleep apnea should be offered the option of surgical referral. In certain circumstances, patients with infertility, severe stress incontinence, severe gastroesophageal reflux disease, or severe arthritis can be considered for surgery. I will describe the more common procedures. Laparoscopic gastric banding promotes weight loss by restricting the amount of food that can be consumed by the patient so that fewer calories are taken in. Laparoscopic Roux-en-Y gastric bypass is considered the gold standard bariatric procedure and promotes weight loss by restricting the amount of food that can be ingested and causing reduced absorption of this food. The patient feels full more quickly and therefore eats less. Surgery usually involves making 5 1-centimeter incisions. A 30cc or golf ball sized stomach pouch is created by utilizing endoscopic stapling devices. The small intestine is then divided and a 100 centimeter length of bowel is brought up to join the new stomach pouch. Downstream from this, a new small anastomosis is formed to restore bowel continuity. The operation takes approximately an hour to an hour and a half to perform. The advantages of laparoscopic gastric bypass over other procedures is that there is greater weight loss and this weight loss lasts for longer. Laparoscopic sleeve gastrectomy is a more straightforward procedure to perform than bypass and is particularly appropriate for patients who are very heavy. It involves dividing the stomach with a stapling gun and removing 4/5 of the stomach. What is left is a narrow gastric tube. The initial diameter is slightly bigger than that of a pen. The rationale for a sleeve is that it is a good standalone operation, but also is easy to convert to another procedure if the patient does not lose enough weight. How much weight loss occurs after surgery is a question that's frequently asked by patients. The average weight loss at a year after gastric bypass in my patients is just over 6 stone or 71% of the patient's excess weight. This tends to be greater if the patients are heavier to begin with. After sleeve gastrectomy, the average weight loss at a year following surgery is over 7 stone. What are the medical benefits of having surgery? This table details the effect of bariatric surgery on patients attending the Bon Secours hospital with high blood pressure. Of a total of 108 patients who were diagnosed with high blood pressure preoperatively, 68 or 63% were cured of the condition and off all medications by 12 months postoperatively. There's a similar high cure rate for diabetes. Of the 50 patients on oral medications preoperatively, 80% or 40 were off all treatment by 12 months postoperative. There is also a high cure rate for other medical conditions such as sleep apnea, where over 70% of patients come off their CPAP masks. Urinary incontinence, which is cured in over 40% of women, and gastroesophageal reflux disease, which is cured in over 80% of patients. The bariatric unit at the Bon Secours has been performing obesity surgery for the past 7 years. During this period, over 350 patients have benefited from the dramatic weight loss and improvement in their medical conditions. Patients are referred from all over the country, including many from Dublin, Galway, Limerick and Sligo. We are a large and very experienced multidisciplinary team of dietitians, physiotherapists, psychologists and medical consultants experienced in radiology, cardiology, endocrinology, gastroenterology and respiratory medicine. We have recently been accredited by the International Federation for Surgical Obesity as the first and only Irish Centre of Clinical Excellence in Bariatric Surgery. This accreditation was based on a site visit from the European headquarters of IFSO and detailed evaluation of the facilities at the Bon Secours and detailed review of our patient outcomes. Thank you.